And now we're on to the pathology section of the chapter. While this is definitely where the bread and butter of the chapter lies, also be forewarned that there are a lot of diseases listed. Remember this as a section to come back to a few times, to review the major diseases covered, and to look for key distinguishing features for each disease to keep them all straight. We'll try to present the key clinical scenario relevant for most of these disease processes. The first disease we'll discuss is called achondroplasia. Remember the concept of endochondral ossification that we just discussed? This is what happens when it doesn't work. Normally, patients would put down a cartilage framework to help form the structure of their long bones before forming bone over the scaffold. In this case, a constitutive activation of FGFR3 inhibits the chondrocytes from proliferating. This means patients can't grow out their limbs and will end up short. That said, remember not all bone grows by endochondral ossification. In fact, there is no problem with membranous ossification in these patients, so they will have a normal-sized head and trunk. Though because their limbs are short, they will appear disproportionately large. There is a huge spectrum of osteochondral dysplasias, the family of diseases that includes achondroplasia, but this is one of the more common ones. So what will they ask you about this curious disease? There are a couple of high-yield concepts about achondroplasia that you should know. First, this is one of the few diseases that actually increases with advanced paternal age. Most patients develop a disease spontaneously, but if it is inherited in an autosomal dominant fashion. Another important fact to know is that these patients will have a normal lifespan and normal fertility. Osteoporosis is an extremely common disease, and as is the spirit of the Step 1 exam, common diseases are always well represented in their question bank. Osteoporosis is defined as a reduction primarily of the trabecular bone, despite normal bone mineralization in lab values. There are technically two different types of osteoporosis. Type 1 is postmenopausal, wherein decreased estrogen levels cause increased bone resorption. Type 2 is likely different, wherein slow but steady loss of bone mass with age leads to osteoporosis. Clinically, patients are assessed for osteoporosis using DEXA scan. Their bone mass at multiple different sites is measured using this scan and is compared against bone mass for young individuals. If their bone mass is less than 2.5 standard deviations from the mean, they are considered to be osteoporotic. If it is less than 1 standard deviation from the mean, they are considered to be osteopenic. There are many clinical signs of osteoporosis. The first one, and one of the more common ones, is vertebral compression fractures. These clinically present as acute or subacute back pain, sometimes after mild traumas, but often after no real trauma at all. Patients with osteoporosis can simply step off a curb, and the impact of putting their foot down that single step can actually cause a vertebral crush fracture. The classic clinical sign for this is point tenderness over the spine, usually along the thoracic spine. Often, these won't fracture quickly, but rather will fracture gradually, leading to multiple subclinical vertebral fractures. These won't present as back pain, but rather loss of height and kyphosis. Just imagine a 5'2" woman who then gets her height measured at 4'10" at the doctor's office. A second clinical presentation is with a fracture of long bones, like the femoral neck fracture, or the distal radius, which is called a Colles fracture. A classic question they like to ask about patients with osteoporosis is the medications that you can give them, not to treat the osteoporosis, but rather to treat other conditions in patients with pre-existing osteoporosis. Remember, old people fall down a lot. If they have osteoporosis and they fall down, they break bones, and in some cases, they even die. If you give them something that can cause them to fall down more, they will break more bones and have an even greater chance of death. So you'll have an old patient with insomnia, and they'll give you 4 options. Say zolpidem, a benzodiazepine, and diphenhydramine are the first 3. All of them would work, but they would all increase fall risk. The 4th option would be to screen for depression, not a first choice for all doctors, but definitely safe to do, and worth doing because remember, depression in the elderly can present atypically. Remember to screen for depression. So if a patient actually does have osteoporosis, what can they do for it? For one, they can reverse time and start exercising and increase calcium and vitamin D intake to improve peak bone mass. But since you can't actually reverse time, you still have a few other options. One option is to use bisphosphonates, which are very commonly prescribed. Other options include SERMs, or selective estrogen receptor modulators. You can also use calcitonin or pulsatile parathyroid hormone. We'll discuss the more common ones in the pharm section. Before we move to osteopetrosis, one final fact is that you can't use drugs whose side effect profile includes loss of bone density. Any ideas what drugs this includes? Glucocorticoids are the classic ones. You'll read in your pharm chapter that it also includes heparin. Osteopetrosis is an interesting disease and relates to an aspect of bone growth that we haven't touched on in much detail. When you form bone, there's sort of a battle that is going on between osteoblasts and osteoclasts. Osteoblasts are forming bone quickly to ensure growth progresses steadily, but this often leads to bone being formed in a way that is a bit haphazard and not refined into a good structure, like that which is needed in healthy, mature bone. Luckily, most people have osteoclasts to resorb and shape this haphazardly placed bone. This ensures it is mature and well organized before it is finished. However, patients with osteopetrosis don't have normal osteoclast activity. This leads to them having thick, dense bones that are made of an immature substance, so even though you'd think they would be extra thick and hence extra strong, they're also very immature and actually prone to fracture. In normal, healthy bone, the center of bone is hollow enough for bone marrow to fill in. However, when bone growth is dysregulated, like in osteopetrosis, the marrow cavities are actually filled in. This leads to the most devastating problem, which is hematopoietic. There is anemia, thrombocytopenia, and increased risk of infection. This causes an increase in extramedullary hematopoiesis. It does not, however, cause any changes in serum calcium or phosphate, or in ALP or PTH levels, much like osteoporosis. The gene defect to recall for osteopetrosis is a genetic deficiency in carbonic anhydrase 2. The X-ray findings are classically noted as Erlenmeyer's flask bones that flare outwards. The clinical pearl that you need to remember, the sort of physical exam sign that would make you think osteopetrosis, occurs because bone enlargement impinges on cranial nerves and leads to palsies. Osteomalacia is a disease wherein bone is not mineralized appropriately. Basically, this results in bones being softer than they should be. Osteomalacia, translated from Latin, means soft bones. It is caused by a deficiency in vitamin D. Vitamin D, as you should remember from your endocrinology lectures, is an important regulator of calcium levels in the body. Because calcium is low, patients will have a reflex increase in PTH, which will also decrease phosphate levels. Remember that PTH is the phosphate trashing hormone. If you are suspecting osteomalacia, these lab values would definitely confirm your diagnosis. The term rickets is not much different from osteomalacia, except that it refers more specifically to vitamin D deficiencies in kids. Paget's disease is quite interesting, particularly because the cause remains unknown. Osteoblasts and osteoclasts in the body both function, but work abnormally here. This causes the bones to appear much different than they would otherwise in a healthy individual. This appearance is not only at the macroscopic level, but also at the microscopic level, when looking at the architecture of the bone histologically. The thought is that a viral illness may play a part in its etiology, but this is still not confirmed. The classic lab value that is abnormal is increased ALP. This is a fact that you may see on the boards. With diseases like Paget's, there are two things you should pay attention to. A, you should know the key catchphrases that will make the diagnosis, and B, you should know how the disease will kill you. So first, the catchphrase mosaic bone describes the macroscopic appearance, and even on imaging is a giveaway. Long bone chalkstick fractures are also common. Imagine the way chalk breaks, with a straight line across it axially. Healthy bone doesn't do that because it's designed to have a lot of resilience in that direction, but for patients with Paget's, it is much easier to break the bone. And how will it kill you? There are at least two ways it can kill you. The first is that AV shunts form throughout the bone, causing high-output heart failure. It can also lead to osteogenic sarcoma, again as a result of disordered bone growth. The classical vignette will likely have an older male with increasing hat size and also a possible hearing loss because of narrowing of the auditory foramen. While the latter could be similar to osteopetrosis, the labs, age group of patients involved, and additional clinical findings all should help you differentiate the two.